Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Hello, and welcome back to the PEM Chat podcast. I'm glad you guys decided to join us today as we finish up our two-part series with our clinical pharmacists, Maggie and Morgan. On our first episode a couple months ago, we talked about antibiotics, and today we're going to talk about all the other common medications that we use in the emergency department. So welcome back. I'm glad you're here. We're going to jump back in. Today, we're going to do something fun. We have two of our pediatric clinical pharmacists here with us to talk about medications. And honestly, this episode was inspired by a chart review I did pretty recently. I was looking through a chart at one of our community hospitals, and the APP seemed to have difficulty dosing Zofran, and there was a consult with their attending, and then the patient was not prescribed anything on the way out the door, and they kept vomiting, so they came to Children's later that day. And I thought we probably really take for granted how much we use these medications. We're dosing these every day and using these medicines so frequently. We don't think about how people might not be familiar with some of the really simple things that we do at Children's. Let's start with kind of a general question. What would you say is the biggest pitfall you see in pediatric prescribing in our department?
In our department? Ooh.
Or anywhere.
I think in general, especially for places that aren't pediatric specialized, it's okay, the provider orders what they want. They order the dose, but translating that into a safe volume and the right volume to get to the pediatric patient, I think is a really, I don't want to say challenging, but a high risk part of it. So yes, the provider clicks, whoop, I want Ceftriax on this dose, and in adult land, they just get these dosage forms that are appropriate for basically any adult. Right. Whereas in pediatrics, you could have a 1 kilo patient, a 2.2 pound patient, or you can have someone that's like 300 kilos. So really kind of combing out what they need, what is safe for them, and then also finding like the right indication specific dose and clicking through. We go on Lexicon through Up to Date. We have that available to us, but kind of balancing that dose with how to get it to them, I think is where we kind of fit in quite a bit in our job.
I wouldn't know from the pharmacist perspective, but I think because we're children specific, we probably do pretty okay. Do we do okay, girls?
Yeah. I think it's a lot better for us when everyone's used to it, whereas when another ER, especially, gets a critical kid and they're like, what do we do? This is a tiny kid. They shouldn't get a full dose. And yeah.
Well, I thought we would start with the basics. So Tylenol, Ibuprofen, our antipyretics. And you may or may not know weight-based dosing here, but this is something we super commonly use in our department. So let's start with Tylenol. Who wants to take Tylenol?
I can take that one. Usually in our department, we do a dose of 15 mg per kg, and then to a max daily dose of 75 mg per kg per day. And so you can do that every 4 to 6 hours. If you did that dose every 4 hours, you would max out your dose, total daily dose. But usually we're spot dosing, and so that's what we do in the ER.
Is there a difference between infant Tylenol and children's Tylenol?
No, so they are the same concentration. So they are 160 milligrams per 5 mLs, and that is what we thought was only available outpatient. So a little twist to that, I guess one of our providers, I don't know if you've heard about this, Toni, found a parent with a different concentration of Tylenol in our community, which is really scary to us because a lot of our providers on discharge will give this mLs, again, translating the dose to the volume that either our nurses or our parents are going to give the patients. So we just, as a group, as everyone in the U.S., thought that there was one concentration of Tylenol available, even though they are marketed a little bit differently. But I guess there is a different concentration for sale in some Hispanic stores around. And I think it is 100 milligrams. Did I write it down?
100 mg per mil.
100 milligrams.
Oh, wow.
So
that's
threefold difference. Yeah. So that's a little bit scary. So whereas the providers before would just put the mLs of Tylenol to give whatever product, now I think we need to be careful about pointing out that there are different products available.
Okay. Yeah, that's great advice.
But the infant versus children's, they just have different directions on the boxes, I think. I don't know why they do that, but probably to make you buy a new one when your child grows up.
Well, I tell parents, obviously the infant is, they come with a small dropper and it's easier to get, I guess, measure those small quantities, but they charge so much more money for it. And it's the same medicine. I'm always telling parents, like, save your money and just buy the generic children's Tylenol because it's the same thing. And that's really the take home there. But
yeah. And if you're having trouble, like, or if a parent's having trouble, like, finding a good way to measure those small amounts of medication, pretty much any retail community pharmacy, you can walk up to the counter and ask them for syringes, and they will give you syringes.
Great.
And that's a lot more accurate than, like, the teaspoon trick that I always got medicine from. So we love our oral syringes.
20 years ago when our parents did that? Yeah.
And it's so much easier to squirt a syringe of medicine in a kid's mouth versus trying to get them to, like, drink out of a spoon or a little cup.
For sure.
I don't know. I'm horrible at giving my kids rectal Tylenol for the win, which is another point on Tylenol. We have rectal formulations in the hospital and in, like, a retail pharmacy. You could buy it for outpatient use. So for your little kids, getting your right dose in the suppository and giving them that rectally when they're sick and crying and screaming and barfing is great.
Yeah. Or your picky autistic kid that won't take any medicine, So yeah, I love that. Okay, who's got Motrin?
Yeah, so Motrin, there is a difference in your infant Motrin versus your children's Motrin or ibuprofen. So your infant Motrin is a concentration of 50 milligrams per 1.25 mLs or 40 milligrams per 1 ml. And then children's Motrin is 105 mLs or 20 milligrams per ml. So it's about 2 times more concentrated as an infant Motrin compared to children's Motrin. So again, as we were talking about with the other Tylenol that we found floating around the community, it is important to make sure parents know that there are different concentrations and making sure that we know how to translate what the volume of medication is going to be based on what product they're using. But both of them are safe to use at any age. You can use the infant Motrin for a 12-year-old if you wanted to. You just have to make sure you're giving the right dose and volume for the product that you selected.
Right. But not under 6 months, right?
Correct. Not under 6 months. There is some use for NSAIDs under 6 months, but for Tylenol or for pain and fever management, we have a minimum age of 6 months.
Why do we not use it in babies under 6 months?
So early on, we use it for PDA closure in our, like, neonate babies. But we really try to not use it under 6 months because the kidneys aren't fully functioned yet. I like to say babies' kidneys are down. Really, like, babies' bodies in general are done, but the kidneys haven't figured out how to clear those kind of medications yet. And so it can cause some kidney issues or some kidney failure if you are giving it in kids too young where the kidneys haven't figured out how to get rid of it yet.
Yeah. So no ibuprofen until they're 6 months old, Tylenol only until then. Of course, if you're talking about little bitty babies, less than 3 months, I would say send those to the hospital because that's a Feb Neo category and we probably need to check that out, or at least get seen by their pediatrician. Okay, and then is there a rectal suppository for Motrin?
There is not.
So I heard Access Pharmacy can compound that. Have you heard that?
Did specifically the ibuprofen?
Yeah.
Okay. When I left for maternity leave, I was, like, gonna call and ask if they could because we've done some stuff with antibiotic suppositories, but I don't think I ever called. But that would be great. I think in other countries it's available. I don't know why it's not commercially available here, but
yeah, I've kind of looked into it. There's not a whole lot of studies on its use rectally, and I think probably the concern is that NSAIDs can cause an increased risk of GI upset and GI bleeds. So putting it straight up into the rectum could potentially cause more irritation than Tylenol. But if it's something that we find more information about or studies on, I would be really happy to be able to find it.
Okay. Let's move on to antiemetic medications. This is probably the second most common thing that we do in the children's ER. We do this all the time. And our most loved medication is Zofran, and I think that's true for... Hey guys, well, I wanted to jump in here and really just quickly give you a little update that has changed since we originally recorded this podcast. We recorded this a few months ago, and today is December 3rd, 2025. And I was reviewing these medications on Up to Date, getting ready to publish this podcast. And I noticed that Zofran had changed. So in Up to Date, if you looked up Zofran a few months ago, it followed the FDA prescribing guidelines pretty strictly. So it said Zofran was approved 6 months and up for the treatment of acute gastroenteritis symptoms. And it was approved to treat gastroenteritis symptoms for chemo-related symptoms or post-operative nausea and vomiting in infants that were much younger, down at 1-2 months along. So definitely used in that younger age range. But for the ER, which is where we're working, those acute gastroenteritis symptoms, it was 6 months and up. And you saw a little variance in our group. Some people felt more comfortable using Zofran in younger ages, and other people did not and really stuck with the 6-month rule. Now, the FDA guidelines have not changed, but the recommendations on up-to-date changed. So now when you go to up-to-date, you'll see that they recommend the use of Zofran for 3 months and up, which is very different than what it looked like just a few months ago. So now the question is, with knowing that the FDA guidelines have not changed, but the recommendations on up-to-date have changed, based on the fact that it is used successfully and safely in these younger age ranges for other indications, so why couldn't we use it in the ER setting as well? Would you use it? I don't know. I think everybody's going to be a little bit different. Everybody's going to have a different opinion on how they want to walk this line. I tended to be somebody who was a little bit more liberal with the use of Zofran. So if you were 5.5 months and super chunky, I probably was going to give you Zofran. So I think I will use it down to 3 months based on this recommendation. But then the question is, do I prescribe it, right? Do I send you home with that medication? And then how am I going to do it? Am I going to give you an ODT, which I would do for older kids that I can't weight-based dose? Or am I going to give you liquid and take the risk that maybe you can't tolerate it PO for vomiting? It's an interesting question, and I don't know that I know the answer or even what I'm going to do yet, but it's something to think about, and I just wanted to bring this to your attention as we jump back into this section and finish talking about Zofran use. And I think that's true for most people. We like it because it doesn't cause the sedation that all the other antiemetics generally will. And so in kids, we don't want to make them sleepy all day and make them grouchy, and it can make them very irritable too. So we love Zofran, and our go-to for most children is a Zofran ODT. Tell us about how we dose that and who we give it to.
Yeah, so you can kind of use like flat weight-based dosing. So what we do in our children's ER is kids that are less than 15 kilos get 2 milligrams or half of a 4 milligram tablet. And if they're 15 kilos or greater, then they get a full 4 milligram tablet. If you get over like 30 kilos, you could probably give like 8 milligrams. We usually don't do that. We usually just give 4. And then if it doesn't work, you can always redose the 4, but we usually don't start with an initial 8. You can give that every 6 to 8 hours. With the caveat of some of your littler kids, so less than like 7 kilos or so, you might want to be looking at our weight-based dosing, which is up to 0.3 mgs per kilo. And sometimes Maggie and I both will recommend switching to the oral solution at that point, because you can give a 1 milligram dose, which is a little bit safer and more within their weight-based range. But the downside of the oral solution is I don't think it tastes as good. The ODT tablets taste like strawberry and they dissolve really quickly. So once you get them in someone's mouth, you should be absorbing them pretty quickly. Whereas the oral solution, you have to get the kid to really swallow it for it to work. And a lot of them like to throw it up as soon as they get it in their mouth. And the oral solution is a little bit harder to find outpatient. So we give the 4 milligram ODT tablets to adults. And so pretty much any retail pharmacy is going to carry those, and they're easy to split to get your dose, either 2 milligrams or give a full 4 milligrams.
Another nice little pearl here is we tell parents that little kids cannot tell you they're nauseated. And they have difficulty communicating that to parents. They will just stop eating and drinking. So in general, our instructions are give this medicine for vomiting or if they're refusing to drink. So, our approach to a kid that won't drink is, are they having pain? Are they having nausea? We'll treat those two things and see if they get better. So I'll typically write that on the prescription, 2 milligrams Q6 to 8 hours as needed for vomiting or not drinking. It's a great medicine, works I'd say 95% of the time. And of course you can give it IV as well, but we love the ODT and our nurses have that on protocol. They do it at the door if the kid's vomiting. So nice little pearl you can use in your community ED if you have ODTs. And I would think, would you say most hospitals have ODTs?
Definitely.
Yeah. Everywhere I've been has had it.
Okay. And be sure to prescribe the ODT. Yeah. You don't want to give a kid a pill. They are not going to swallow it. Like, I think it was Morgan that said you may not get the liquid. It's also expensive. And so I've heard that some people need a PA and they can't get that medication sometimes. So use the ODT. They're very inexpensive and most patients can get those. Okay. With regard to the other antiemetics like Phenergan, Compazine, Reglan, I know these all have some side effects we don't love. Tell us a little bit about those medicines.
So, To start off, I do want to warn they are on the kids list, which is like a potentially inappropriate therapy medication list in young kids. So they recommend absolutely not using them for under 2 years old. And then we're probably not going to use them till we're approaching puberty, teenagehood, usually in our patients, maybe 6 or 7. But really, you want to avoid all of these in the young babies, especially in the ER. Sometimes like chemo regimens and all that have those included, but we usually want to avoid them. Some side effects are that it makes the kid extra sleepy. They all work on the dopamine pathway, but they can have some like dopamine side effects. So like movement disorders, or the one we've been seeing in our ER a lot is the akathisia.
Akathisia, yeah.
Where it's like a feeling of movement and restlessness and needing to get out of your body and freaking out. We've been seeing that one a lot actually in our ER the past couple months.
And that is terrible in like a 4-year-old. Like it is.
That doesn't know what's going on or anything.
They're screaming and the parents hate you and they're just like, fix it. And you know, you can't fix it. It's a horrible situation to be in. I've done that. So don't do that. All right. Sorry, Megs.
No, all good. And then the Phenergan specifically is really like caustic to veins. So if that drug extravasates, you can see some really bad like tissue necrosis possibly. So that's one that always flags in my mind is like, hey, I'm going to go talk to the nurse if we are giving this and talk about how to dilute it and give it slowly, especially in our pediatric patients. My old hospital actually took it off formulary for all kids at one point because it is on like this high risk medication list for everyone. And so we would not give it IV in kids. You could give it oral or rectally. And then our adult side made all the doses in the pharmacy and diluted them out pretty far. Sorry.
Do you feel the same giving it orally?
The side effects other than the like extravasation, yes, would be the same.
Yeah. I found like if I've failed Zofran and then I have to use something else, if I had to choose one of these, I would probably go with an oral medication because it seems to have less side effects. Just that might just be anecdotally on my part, but
yeah, I think probably less, but they are still a risk to taking the medication. The like akathisia one that we've been seeing a lot specifically with compazine, I think is reduced in oral use and possibly giving it more dilute and slower, but it's still a listed complication of using that.
I came from OB, and I'm sure you guys know we don't use Zofran the first trimester, and so we are giving tons and tons of Phenergan and compazine. And great success in adults by diluting it like you're talking about. I used to put the compazine in a bag of fluid and run it over an hour. And so I had very few side effects doing it that way. But man, I hit children's and was like, oh, I got to stop using these medicines. Like it was incredible how many reactions that I had, and it's miserable. So yeah, I would say definitely start with the Zofran every single time unless they have an allergy. If you had to pick one of, Phenergan, compazine, Reglan, because they have a Zofran allergy, what would be your first choice? None of them?
Morgan, you want to take this one?
I think it's going to depend on a lot of things. So like patient specific things, what's their age? Like have they tolerated any other anti-nausea medications before? Like has something worked for them in the past? I think a Zofran allergy truly is very rare. Mm-hmm. So I don't know if I would have a specific recommendation or have come across that before. Something else I wanted to mention with Phenergan, though, is that for adult-sized patients, it does come in a suppository form. So that is a really nice option if they truly can't tolerate anything by mouth. You see it a lot more in like older kids or adults for migraines specifically, but that is something that's commercially made. And it's easy to get in an outpatient setting.
Yeah. What about old school Benadryl?
So I like Benadryl. Again, based on the patient, it depends on because kids specifically can have like a paradoxical reaction to where instead of the Benadryl like helping make them sleepy or it makes them super agitated and like wired. So if the patient has tolerated Benadryl before and doesn't have that paradoxical reaction, I think it can work really well in nausea. Now, how that exactly works and how often we use it, I can't really speak to that a whole lot. I'm fully convinced Benadryl works pretty well in nausea just because you can't be super nauseous if you are sleepy.
If you're sleepy. Yeah. Well, when I worked here before, like that was our go-to drug. Like that was what we used. That was first line for nausea in kids 20 years ago. I'm just a lot older than both of you.
I feel like we see Benadryl And then also lorazepam or Ativan or some of our benzodiazepines used a little bit more for nausea in our patients that have prolonged QTC. So pretty much every single anti-nausea medication that we've talked about so far has a risk of prolonging QTC. And so if you have a kid that has a prolonged QTC, whether it's because of like drug induced or like an ingestion, or you can have congenital prolonged QTC, those are good options since they don't have as much of a risk of increasing your QTC.
Okay. And I would say, as an APP in the ER, if you're running out of options, call your pharmacist, right? I think when I first started practicing, I didn't really think I could do that. And having you guys in the ER has really taught me that having a pharmacist on your side is a really amazing benefit. And if you work in a hospital, you have a pharmacist. So pick up the phone and call your pharmacist. So I call the pharmacist all the time. Maggie, Morgan. But I also call Jeff, and I call the pharmacy too, and when you guys aren't there, and just make sure things are right. I mean, it's an easy thing to do, and that's what you guys are there to do. And nobody in the pharmacy has ever been irritated by my questions. So
these pharmacists like answering questions.
Yeah,
I would say another thing, like we're helpful on the ED side and the inpatient side with like selecting medications and dosing, but also most of your pharmacists that work in a hospital setting probably have some type of retail experience as well. And so some of them more often or more recently than others. So like I call Jeff a lot on the weekends that I work because he has worked in retail very recently in the Chattanooga area. And so they're very skilled and knowledgeable about like what products can you find outpatient and is it going to be expensive? Does it require a PA? And so I use them a lot to help me decide like, is this something that we think this patient actually could get when they leave our ER and try to go pick it up somewhere?
Yeah, nothing more frustrating than sending somebody home with a prescription and then they have to call the ER 16 times because they can't find the medicine. Yeah. I called him recently because we had to treat Giardia and I guess whatever, I don't even remember what the first line recommendation on UpToDate was, but you can't get it. Like it's not going to happen. So we went with the Flagyl. But anyway, all right, cool. Well, let's move on to pain control. So this is probably the next area where we do a lot of this, and kids are pretty amazing. They do really well with ibuprofen. We use ibuprofen a ton for pain control. We use the same dosing that we do with the children's ibuprofen, the 10 mgs per kilo for pain dosing. And if you come in with abdominal pain, and you don't look like you're in acute distress, I often will use that first line. But if we don't, we can also use, if we need to do something IV, I will sometimes step that up and do Toradol. Let's talk a little bit about Toradol and how we use that in the children's ER.
Yeah, so this is more or less the IV version of ibuprofen. It can also be given IM, right? We don't like to do that a lot, but yeah, it could be given. If
Kids do not like being stuck with needles.
And it can also be given PO, which is not as common because we just have the easy ibuprofen that is just everywhere in the community. I think we can use it greater than 6 months, but we do like to use it usually over 2 years because that's how it's studied the best. There are some studies that look at post-op use in kids down to maybe 1 month old, I think. But that
I've never used it that young.
Yeah, that's a whole different indication. And again, like we said, the kidneys are kind of dumb in that age group. Maybe avoiding that, using it maybe greater than 6 months or definitely greater than 2 years. And we like to make sure they haven't taken ibuprofen recently. Sometimes you can slip a dose in a little before the 4 to 6 hour mark if we need to, but usually we would alternate like the ketorolac with the ibuprofen.
Yeah. And I usually use this for migraine headaches and abdominal pain, probably the two most common things that I would use that for. On the adult side, this has been studied a lot, and there's a ceiling dose of Toradol of 10 milligrams. So I generally cap it out at 10 milligrams, but they come in 15s, right? Isn't the vial 15 or is it 30?
It's 30, I think.
30 and 30, yeah.
Okay. So a lot of people will just order 15, and in our little click boxes it says 10, 15, and 15 is half the vial, so that's a little easier for people to calculate. We used to give 30 and 60 milligrams at a time, so this, it's peanuts what we're talking about, the difference between 10 and 15. It's probably not going to make a huge difference. But if they are, smaller and we had to do a weight-based dose, what would you say the dose would be?
I think it's 0.5 milligrams per kilo.
Yeah.
Okay.
And then another thing on this is if you're prescribing it for outpatient dose, you don't want to give it past 5 days of therapy. They should really only be using this for 5 days.
Yeah. And I think the only thing I see this commonly used for at home in the ER is kidney stones. I had one yesterday. But I don't think I've ever prescribed Toradol outside of a kidney stone, and just making sure their creatinine is okay before you do that. Okay. Next, we're going to talk about some of the narcotics. This is an interesting topic because at Children's, we get a lot of transfers, and we often get calls where people are not treating children's pain. And so I really wanted to talk about this and say, hey, you know, if your kid is in acute distress or has an angulated fracture, like, please treat their pain. You know, don't be afraid to give a kid pain medicine. Are there any pain medicines that are contraindicated in children?
I don't think so.
Right?
Other than your age restriction, on your NSAIDs.
Yeah. I used to get this question in OB all the time. I'm like, they're not aliens. Like, you can give them these medicines. Like, please treat their pain.
Yeah, we use it in neonates all the time, a lot of them.
So, yeah, you do not need to be afraid of these medications in children.
Do be afraid of the dosing.
That's what I was going to say. But you do need to know how to dose it, right? So let's talk about how we do a weight-based dose of, say, morphine, which is probably the most common drug that we use.
Yeah, so our weight-based dosing of morphine is 0.025 mg per kilo. You can go up to 0.05 mg per kilo per dose. We usually cap it at like 2 milligrams, maybe 4 milligrams if it's a really big kid. But I think with all the pain medications, specifically opioids, I think people get really worried that you're going to cause this kid to go into respiratory depression. You're going to have to end up intubating them or bagging them or giving them Narcan or something. I think the general rule of thumb is if you're worried about that, give the smallest dose range.
Right.
And then you can always repeat it if they tolerate it well. As long as, if they're still in pain, you can always give more. You can't take it away. So that's always one of the things that I recommend. They're like, oh, I'm scared. They're opioid naive. I've never given them this before. I'll say, like, well, give like the smallest dose or round down a little bit. And then if they're fine and they're breathing and they're still in pain, you can always give it again. You just can't take it away once you give it.
Yeah.
Well, you could give Narcan.
Yeah,
but you don't want.
Isn't it true? I find that most people underdose morphine, like as a whole in medicine, like especially in adults. Like even in adult land, people would start with 2, and the patient's 350 pounds, and I'm like, you might need to give them a little bit more. You know, I think we're all a little nervous, but I haven't actually had a patient go into respiratory depression with morphine in my career. I've seen it with high doses of Sedation, but that's the only thing I've seen. I guess maybe if you were given like 10 or 15 milligrams, but 2 to 4 milligrams is not very much. But I will say, if you just click on the box for a weight-based dose here, sometimes it will come up and it'll be 8 milligrams because it's a big kid. And I don't do that. So that's probably a kid I'm going to give 4 milligrams to, maybe 2. And I think it is wise to be conscientious when they are opiate naive, because it's going to hit them like a ton of bricks, and they're going to feel funny, and they're going to, probably be complaining about that to their parent if they're awake. So a little bit goes a long way, and you can always add more. I think that's great advice.
Yeah. And something that you just made me think of with that 8 milligram dose that I always like to tell people about pediatric dosing is we usually cap most medications we cap at an adult dose. And pretty much every manufactured product that's on the market is made for adult dosing. Mm-hmm. And so I always tell new nurses or new pharmacists, like, our morphine comes in 4 milligrams, like little pre-filled syringes. And so like if you're having to use more than one container size, then that might be a reason to double check or question what dose you're giving and if it's too high.
Yeah, that's a red flag if you're getting out multiple containers.
Yeah.
Always.
Okay.
Usually.
So we do not do intranasal morphine where we are. Is that a thing?
I've never seen it. I don't think there's any dosing for it.
Okay. All right. I was just curious. All right. Next is fentanyl. And this is an interesting drug to use in our current climate, because you say that name in the room and parents go, oh my God. I've even had children say, oh, that's bad. I am not taking that. They get really upset about this medicine.
Seen that on a billboard. Don't use it.
I know. Yeah, it's entertaining, but I'm always like, these are micro doses compared to what people are using on the street. And it's a great medicine with a really short half-life. I've used it in multiple settings in the hospital, and I love the fact that they're not like hung over for hours and hours and hours with this medicine. So it can get you some really good relief really quickly, but not last forever. So we give this IV, and we also give it intranasal. And so who wants to talk about fentanyl?
I can do this one. So our intranasal dosing is 1 mic per kilo up to 2 mics per kilo, I've seen. I think that's what our protocol is. And that's a little bit higher dosing than IV. So IV dosing, you probably wouldn't go above 1 mic per kilo to start, and you could round down or do half a mic per kilo.
Yeah. And to be clear, she's saying micrograms.
Oh, sorry.
Yeah.
Micrograms. Yeah. Not
Yeah.
milligrams, but I don't think you'll give a dose in milligrams. It is dosed
Yeah, I
in
don't think anybody
micrograms.
will let you do that.
That'd be a lot of dosage forms of this. And so our nurses draw it up. It's a concentrated product. It is 50 micrograms per ml, and they will use a nasal atomizer to give it and for the intranasal doses. And I don't know if our child life specialist touched on how to give it, but they can help give it. And then our pediatric nurses are pretty well versed in giving it, but I don't think they prime the little nasal atomizer, do they?
I don't know. I was going to ask you to kind of tell us what an atomizer is in case you've never seen one of those.
Yeah, so it's a little like piece of foam, I would say, that's shaped like a triangle, like a cone. And then it locks on to the end of the syringe. So you'd pull your dose up with the needle and then take your needle off and put this little cone thing on the end. And then that will go in the kid's nostril. And it'll basically, like when they push the plunger, it disperses it out to kind of fly out. And that just disperses it through the nasal mucosa to be well absorbed, basically.
So even if they're not inhaling, it should work.
It should. And I think they actually say not to inhale because you don't want the drug to like be swept back into their respiratory tract. You want it to sit. So they might need to inhale a little bit to like pull the drug in, but not like all the way back to their lungs.
Yeah, you can tell I've never used one of these items. Our nurses do it, but so I always thought you had to like inhale because I hear them telling kids to do that, but I thought, man, how do you get a little kid to do that on command when you're shooting something in their nose?
Yeah, I think it's a balance because you don't want it to drip out, but you also like want it to stay there a little bit. So
I think you kind of want to tell them to just like kind of breathe in normally while they're doing it instead of like doing a big like sniff, because that should help keep it in their nostril but not take it into their lungs.
Okay. I hear it burns. Do you know?
I also have heard that. I haven't ever used it.
I haven't either.
Yeah, and the onset of action for this is about 10, 15 minutes, which is lovely. We use this very frequently when we have a kid that comes in with like an angulated fracture, and we know we need to do imaging, and that's going to happen within the next few minutes. And so we want something for pain control right then. We also very commonly use this for burns because they come in and they're in acute distress. And so this is a great, like, fix that pain fast, and then you can do the rest of the things that you need, and they've got a little sedation.
Yeah. And I think also point out that we usually only use our intranasal medications or pain medications if the kid doesn't have an IV.
Mm-hmm.
So it's a really good option, but it works pretty fast if you give it IV too. So this is just a great thing to use if we don't have a line placed yet.
Yeah, you can avoid getting an IV altogether if you use the intranasal medication. So I've done that with a burn where I never had to start an IV for med control because they don't need labs. So I don't need a line for other reasons. So if you can avoid that and you have a non-surgical, non-reducible fracture, that's a great option too, because you don't need the line. So you can just do the intranasal.
Yeah. And I think it's important to think about your safety of doing that also. So it's the same products that we use IV. You draw it up in an IV syringe, and then the only difference is you put an atomizer on it, but your dosing is different. And so just making sure that there's kind of safety nets in place to make sure that we're not giving it through the wrong route. So if the kid does have an IV and using the IV and using the IV dosing instead of trying to give it intranasal, it's also kind of cruel to give it intranasal if they have an IV to use.
Yes.
But just thinking about that, because it is really easy for nursing to draw it up in an IV syringe. They drew up the exact same products that we give IV and just like making a mistake or not really realizing like what route it's going through.
Yeah, that's a great advice. So you're not double dosing them through the IV.
Right.
Yeah. And what is our dose if we give it IV?
Usually 0.5 to 1 microgram per kilo. So about half of your intranasal dosing.
Yeah. And we use our fair share of narcotics in the emergency department. I would say the most frequent things would be, of course, fractures, abdominal pain, stomatitis, which I thought was interesting when I started there. That's probably the most common reason I prescribe narcotics. If you cannot drink because your mouth has a huge, horrible rash in it, I will often send you home with a little high set. Flu myositis, these kids that won't walk, if their kidney function's okay and they're not in rhabdo, then they could potentially get a short course of narcotics. And then, of course, broken bones and injuries like that. So those are probably the most common reasons we would prescribe narcotics on the back end to send them home with something for pain control. But in general, when we're giving people advice on pain control at home for kids, we usually start with our Tylenol and ibuprofen and tell parents if they have pain beyond that and they need something else for control, you can use this narcotic on top of that. Kids are incredibly resilient. They're much, much more tolerant of pain than adults. So
Yeah.
they often don't need it.
I was going to say the great thing about Tylenol and ibuprofen, and a lot of people, I feel like parents don't know this, is that they work very differently and they can be used at the same time. So I think a lot of people have the misconception of like, oh, I can only use Tylenol or I can only use Motrin, but you can give both of them every 6 hours and you can actually alternate them. So they're getting something every 3 hours. And that usually works really well to control pain.
It really does. Our ortho group often tells them just to do the two together every 6 hours, and that makes that easier for parents. And so I'll tell parents that often with injuries and such. So, okay, we're going to move on to something totally different. Enemas. We do a lot of enemas in the children's emergency department because constipation is a really common cause of abdominal pain. And when you have a kid that's still hurting, we like to do something about that to make it better. And so we tend to use, there's lots and lots of different types of enemas out there in the world. And your hospital system is, could look a little different than ours. But what we use is a glycerin saline enema. Let's talk about that just a little bit.
Yeah, so our glycerin saline enema has a 1-to-5 ratio, right? Of
I think so.
5 parts of saline and then 1 part glycerin. So your dose can go up to 20 mLs per kilo, and then there's a max at 800, or sometimes I see 1,000. That's usually provider specific, what they're comfortable with, mLs of that. So like almost a whole liter of fluid that will be given rectally. So if your nurses or you don't have an order built to give this medication, you would take your final volume of whatever the mLs per kilogram are, divide that by 6, and then multiply by 5, and that's how much saline you would put in this mixture, and then times 1 would be how much glycerin you use. And then our nurses, I believe they use, we don't usually make these, but they use a bag with a tube, and they can give it rectally through that way. And I don't know, Morgan, if you can explain that better.
No, yeah, I think that's what they do. They try to mix it up and then pour it in the bag. I think that with the max total, I think a lot of people get really hung up on like, oh my gosh, like what's our actual max? You're hanging the bag to gravity. So I'm always tell people, I'm like, realistically, your max anywhere from 500 to a liter, but if it doesn't fit, it's not going to go in there.
Right. And our providers,
they're pushing it in there.
We're all over the place. Like one of our providers maxes at 300. And then most people max at 800, I would say. And I tend to, like the computer says 20 milliliters per kilo. That's like the standard dose. And I generally make it 10. Except for those days when I make it 1 and Maggie's like, you did that wrong.
Just 10 mLs total.
Right. Okay. Well, when we do these enemas, this was new to me when I came to Children's. A lot of our providers will actually provide a little oral sedation when we do this. And this is something we commonly do. We're going to talk about that in a section coming up, but I just wanted to mention that sometimes we'll give kids at either oral or intranasal Versed before we do enemas, just to help them with the process, particularly if you have like an autistic child or a child that is very anxious. That can really make that process a lot less unpleasant for them. And we also have some people in our group that like to do lidocaine jelly. This was totally new to me recently when we got little messages on our desk about how to do it from you guys. But I guess the thought here is you're just kind of providing some topical numbing, and so it's going to make that a little bit better. Is there specific dosing for the lidocaine jelly, or you just put it on there?
No, okay. So there's really not any data to support its use. I think if you think through why we're using it, it kind of makes sense. Yeah, you're just giving like a little bit of topical analgesic. But I've seen a lot of our providers really only use it in these kids that are like really badly backed up or have really like hard stool balls that it's going to be painful to pass like through the anus. And so you're giving a little bit of topical anesthetic there, but there isn't any data to support that. And there's not really any dosing. So what product we use is the Urijet, which is what they use intraurethral to catheterize patients. So it's safe to use like it has been studied to be used like on mucous membranes, but I'll usually just tell the nurse it comes in like a 5 ml like pre-filled syringe just to squirt just enough out to just coat the anus and not to use anymore. We're really not trying to like insert it up into the rectum, but you're giving it topically. So I think just weighing risks and benefits of how old the kid is and do we really need it, since there isn't a lot of stuff to back up its use. And then it should work or like have some effect within about 15, 20 minutes.
Yeah, I've never ordered that. It was when I saw that on my desk, I was like, what is this? But I have used it for other things. I had a kid pretty recently he had like penile shaft pain and it looked normal and he was having trouble peeing. And so I called the pharmacy and they told me to use the same thing, what they use for catheter placement. So we did that and we had some success using that. So it probably a little easier to use than like just viscous lidocaine, which is going to get everywhere. I'm in my mind, I'm imagining that it's more viscous.
It's more of like a jelly, kind of like, I would say it's more of like a consistency of like a lubricant jelly versus a
liquid
thicker syrup.
Yeah. Okay. All right. Well, good times with Enemas. All right, let's move on to asthma. We take care of tons of kids with asthma. We're about to enter into wheezing season now. So an acute asthma attack, taken care of very differently than, your routine asthma at home. We tend to hit kids we use a protocol to how we do this, but for a kid that's in more acute distress, we use a combination of steroids and bronchodilators. I think, Morgan, you're going to talk about those?
Yeah. Is there anything specific you want to know?
Yeah, I think, from my perspective, when I worked at a community ED, we didn't have the ability to do high dose albuterol, which is what's unique to what we use. So I guess tell us what that looks like for us. And then if you work in a community facility that doesn't have high dose albuterol, and by high dose, I mean like 15 milligrams in a very low volume of fluid so that it can be administered through the nebulizer with a one shot as opposed to putting in multiple because the volume is too high. So I guess just explain what our process looks like if I'm going to give a high dose albuterol Atrovent treatment.
Yeah. So typically if we're giving just like one-time nebs every couple hours or one-time doses of albuterol, we're going to use just the regular nebulized little, we call them little nebs, like it's 1.25 per 3 ml. Maggie, do you remember what it is?
Does anybody use a 1.25 in the ER?
I think we have them loaded.
Yeah, I think usually it defaults to the 2.5.
2.5.
I don't know. Our shelf in the pharmacy, there's like
it depends on
10
what we
different
can get from our
kinds.
Yeah, I know those are prescribed at home pretty readily, but I mean, usually by the time you're in the ER, I'm going to give you probably 5 minimum.
Yeah.
And we're going up to 15 milligrams because you really can't overdose on albuterol. Respiratory likes to say that their heart rate can be too high, but the reality is, like, I don't want to tube an asthmatic, so I'm going to give you albuterol potentially continuously. So more albuterol is better. And, kids tolerate albuterol better than adults. Their hearts are more tolerant of the medicine, so we're pretty liberal. So I guess that's what I was getting at.
Yeah. So that concentrated or like high dose albuterol is typically only used, that product is a 5 milligram per ml product. So it's a lot more concentrated and you get more albuterol for your volume. We pretty much only use that if we're doing continuous albuterol and we're having to fill up that nebulizer more often. That is a product you probably wouldn't see on an outpatient setting just because we're not doing continuous albuterol in an outpatient setting and you're not going to give that much albuterol at one time. And we like to give parents, like, you're going to give this whole container. But I know, Toni, you had kind of talked about you've worked other places where you weren't able to get that product and it's a lot more time consuming for everyone involved that's administering the albuterol to the patient. I know it just is going to depend on what your pharmacy uses as their supplier and what the manufacturer can get to the pharmacy. So we've had issues with getting it in the past. So sometimes we have it on the shelf, sometimes we don't, but it is a great option and helps save a lot of work on hospital personnel, especially your RTs and your RNs that are having to go in there and hand squeeze all of those little nebs into the container.
Yeah, fill it up every 15 minutes.
Yeah.
I asked Dr. Grimes about this because she's like the MacGyver of medicine. And she said, you're just going to have to use either start with your duo nebs, go up to 2. And I forget, can you tell me what's the dose of the Atrovent in a duo neb?
I think it's 500 micrograms.
500.
Does that sound right, Maria? We're very blessed where everything's built out in Epic, and we know it's okay, but recalling it's a little hard.
Yeah. And it's been a few years since I've taken care of adults, so I don't remember. But anyway, we tend to max out the Atrovent at 1,000 micrograms. So you could potentially like dual the two, like you could give 2 duo nabs, which are 2.5 and the 500, and give 2, and then you could just switch to the straight albuterol if you're trying to like high dose the albuterol. But when we give it in children's, I just want to get the message out there that we're giving really high doses of albuterol, and you should not be afraid to use that if your patient's in acute distress, wheezing, hypoxic, all those things, because it's going to help. The other thing here is very well studied and known to, be more beneficial even is getting those steroids on board immediately. At some hospitals, they give them steroids at the door because they take a few hours to kick in. What do we tend to use in our department?
Decadron.
Yeah.
Decadron, dexamethasone for everyone.
Yeah. Why do we love it?
So it has a longer half-life, so it can be given once or daily. Usually it can be given more often than that in some circumstances, but usually once or moving on to Q24-hour dosing for this.
Yeah.
And we in our ER use the IV formulation, and we give it orally. So it's a tiny little volume, and then our nurses will dilute it out with like cherry syrup or what's the powder?
Sometimes they'll mix it with like some water and Crystal Light.
Mm-hmm.
And so that will mask the taste. I don't know what it tastes like, but it's not made to taste good. And it's a tiny little volume, and they can take it easier that way.
Yeah, and if you're in an outside community hospital and you have IV Decadron, which I would wager everyone has, or in a Peds office, you do not have to give this IM. We give this PO all the time. And so we can stop sticking kids unnecessarily and making them mad, which is only going to make their respiratory situation worse. We can stop doing that and give it orally, which is a nice thing to know you can do. So we can potentially give this medicine and then not give them anything to go home, which is really the part we love, right? We don't have to have parental compliance going home and giving this medicine twice a day. I will say that prednisone is your kind of other option that people commonly use. If I remember correctly, it's dosed 1 to 2 mg per kilo per day BID.
You can do it daily or BID. I like daily more often just because it's easier for parents to do.
Yeah.
And if you do it twice daily, which a lot of times people split it because it's just like a lot of volume or it kind of upsets their kid's stomach, I'll usually tell them to take it with breakfast and with lunch, because if you give it after lunchtime, your kid's going to be wired and is not going to want to go to sleep just because it does kind of hype them up. So I try to tell parents, like, if you want to give it twice a day, that's fine, but try it with breakfast and lunch or else you're going to have a horrible bedtime.
I have learned that with like families who have a kid that's a severe asthmatic and they come in for these exacerbations frequently, they probably have had experience with both of these medications and they may have had better results with one or the other. So I'll ask parents, hey, have you ever used prednisone? Have you ever used Decadron? What works best for your kid? Now, if it's their first time or they're kind of new to this, they probably don't know that yet. But most of them, if they've been dealing with this for a few years, have experienced both. And for some people, prednisone, parents feel like it works better. And so I'll tend to use it then. But as a rule, most of the time we're doing the Decadron. That's kind of our first line go-to. How do we dose Decadron?
It's 0.6 milligrams per kilogram. And one of the things we love about Decadron is that it's 100% bioavailable. So your IV dosing and your PO dosing is the exact same.
Yeah. And what's our max?
We usually max, I think,
16.
There's different,
usually.
I say there's different maxes for different indications. So
you can go up to
16,
20 for some things.
Asthma.
Yeah. And that's going to be a little bit specific to your group. We actually had a meeting in our provider group about what we all felt comfortable as the max dose, and we decided as a whole we would use 16. And so that's even higher than what people commonly use in adults. And so, something good to know in kids, you can actually up that dose more than 10, which is what you kind of commonly see in adult medicine. So you can increase that. And then potentially, if you give that one dose, you don't even have to give them another one. Now, if it's a severe exacerbation, you're having to do lots of treatments, you might want to consider giving them a second dose. Some people will do it the next day. Some people will do it 2 days later. There's lots of different ways to do that, but it's something to think about. And I think it's an up-to-date too. It talks about that. All right. Next, we're going to talk about sedation. Now, we're not going to cover procedural sedation because we could probably take an hour to do that. But we're just going to talk about some of the basic things that we could do that could be easily applied in a community hospital. So we tend to use Versed or a narcotic for this. And it's a little bit dependent on your patient. If I have a kid that is autistic per se or not neurotypical in some way, I tend to kind of lean toward a narcotic that's going to have a little bit of, making them sleepy and a little bit more compliant with any procedure we have to do. But if they are a neurotypical kid, I generally start with Versed. Now, that is not a hard and fast rule. I've certainly had kids that were autistic that had surgery and they got Versed and they did fine, and I would probably use Versed in that child. But these are two things that we really commonly use. Talk to us a little bit about how we give that, how we dose that, and what that looks like in our ER.
Yeah, so Versed or midazolam can be given intranasally or by mouth. So they're two different products. They're two completely different dosing schemes. Honestly, I would just recommend to look up your dose when you're going to do it so you don't have to try to remember and flip the doses. And it can also be given IV. However, we're not commonly doing that for just like a little touch of sedation. The intranasal and the oral both work pretty well. And then fentanyl is usually what we use for the intranasal option for the narcotic. And again, we touched on intranasal fentanyl before, same dosing as that we talked about. Again, a little bit different than IV. Fentanyl is not available oral, so that would not be an option.
Yeah. Anecdotally, this is just me personally, I feel like the oral version works better, like if I'm going to do sutures. And this is a little bit departmental specific. So certainly some of our providers have worked in other children's ERs and they would do like combination fentanyl, Versed in low doses for suturing sedation. But at our particular facility, that's considered a procedural sedation. So we can't combine those things. So that's just kind of specific to us. So you have to kind of see what works at your facility. Mags, can you tell us the dose for Versed if we're going to use it orally?
Oral dosing is 0.5 mg per kg up to 20 milligrams. And I recommend to go on your up-to-date Lexicomp drug page to look that up because IV dosing is 0.05. And then intranasals anywhere from 0.2 to 0.7. So it can get very confusing and it's such a big difference that you want to make sure you are getting the right dose of that med for the indication.
And certainly, that max dose is high. And so I've often cap it at 10 and just see how the kid does and before I go up that high. But again, check with your department's rules because there may be some stipulations with regard to where you work on how you give those medications. But we use this all the time for suturing. Also, we mentioned that for enemas. Anything where you need to do a procedure and the kid is, bouncing off the walls or you don't think you can get them to cooperate in a way, or for perhaps you have to suture their lip, and you need to get that right. It's really helpful and can make that whole process so much better. I don't think I did any of that the first year I was in children's just because I didn't know how to do that. And now I'm using it much more liberally and have had much better experiences. And you can potentially save them a conscious sedation, like a whole process of a procedure by doing it that way. So that's something that would be great to know, in an outlying facility. Well, thank you, ladies. We covered a lot of ground and really didn't even touch the surface of what we could be talking about, so many things to cover here, but tons of information. And I can't thank you guys enough. You guys are both amazing and great resources. I love working with both of you. So thank you so much for being on the podcast today.
Yeah, of course. We love working with you guys. I feel like we have a fun group down in the ER and it makes coming to work fun, even when you got to drag yourself there. Usually when I'm there, I'm like, oh, it's a good day. Thank you. Bye.
Thank you guys for being here today with me, Maggie and Morgan, to talk about the common medications we use in the PED setting. I hope we were able to give you some tips and tricks about how you can use medication safely to take better care of the kids you're seeing in the ER. So join me here next month when I'm going to be with Dr. Lindsay McHale, and we're going to talk about the febrile neonate and how to approach this workup. If you're anything like me, I was always not seeing that patient. But now this is actually one of my favorite things to see in the ER. So I hope you'll join us because we're going to break it down and make it a lot more easy to digest. It'll be a great episode, and I hope to see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.